Before that, I really wanted to see that this is a wonderful conference. It is a privilege to be invited here to speak at my hometown, homeland, China, and also that I realized that everybody realized it is a wonderful time for oncology. And if you look at the agents being tested, there is 900 agents being tested in the area of oncology. And the hematological malignancies enjoy the most fast progresses. So it's very exciting. And also we realize that Asia has the largest population among all the continents. I think in the next 5-10 years, Asia would become the biggest clinical trial base in the world. Therefore, there's a lot of work to do. This work will eventually lead to improve the quality of life of our patients and their prolonged survival. So it is exciting. Among all those agents, one of the agents that is showed very good preliminary data is about the Bruton's tyrosine kinase inhibitor, which is called PCI 32765. It was my pleasure that to present this ongoing phase 2 international trial entitled the Bruton's tyrosine kinase inhibitor, PCI 32765, that is highly active as a single agent oral therapy in relapsed and refractory mantle cell lymphoma. And this data came from 8 institutions, and that at the time of the ASH presentation, now 100 patients has finished the enrollment internationally, and which much more centered enrolled patients. The B-cell receptor pathway is a critical pathway in the pathogenesis of B-cell lymphoma and also maintenance of its proliferation and survival of the lymphoma cells. If we target one of the key steps of the BTK, which is the Bruton's tyrosine kinase, has proven to be a key element along this pathway. So it is a critical element along this critical pathway. So developing an inhibitor to target this enzyme, this tyrosine enzyme, could be a therapeutic approach and for the B-cell malignancies. So PCI 32765 is the first-in-class inhibitor of the Bruton's tyrosine kinase. It forms a specific and irreversible bond with the cysteine 481 in the tyrosine kinase protein. It is highly potent in vitro with the IC50s in the nanomolar range. As we can see on the left panel, it is a small molecule. It is orally administered once daily, and also is in preclinical studies, it inhibited the mantle cell lymphoma cell migration and adhesion, and it blocks the many down the stream pathways targets such as NF-kappa B. So in the phase 1, first-in-human clinical trial that includes all the B-cell malignancies, 56, my colleagues, Dr. Giovanni from Stanford, and my colleague Nathan Fowler from MD Anderson presented this data at different conferences, and this data is now in the process of being published. So this trial is the first-in-human phase 1 trial with a single-agent PCI, and the 56 patients with different B-cell malignancies was enrolled. Toxicity was moderate, and MTD was not reached. But based on the preclinical data and the pharmacokinetic PK data and all that, a dosage of 560 milligrams was determined to be the dose to be tested. And among those patients, 7 out of 9 patients had mantle cell lymphoma, and 7 of the 9 patients achieved partial remission or better. More importantly, this duration was durable, and at the time of last cutoff, about 6 months ago, the duration of those people, 5 patient in remission, was between 14 to 29 months. So not only is the oral therapy, single therapy, it also could be potentially durable. Based on these, the bench science, based on the preclinical science of mantle cell lymphoma, and based on the first phase 1 clinical data that mantle cell lymphoma, it might be a very good disease to study with this PCI novel agent. We designed this international phase 2 study that is with a single agent PCI in purely relapsed refractory mantle cell lymphoma patients. The treatment dosage was 560 milligrams daily, and each cycle is 28 days. And the objective was to determine the response efficacy and the safety of this single agent in mantle cell lymphoma, and to determine the duration of response, failure-free survival, PK and PD data, and also quality of life. The efficacy, as we know that bortezomib is approved in the U.S. for the mantle cell lymphoma. Therefore, this cohort was divided in two. That's Velcade exposed, which is 27 patients, and Velcade naive. Those patients never received bortezomib, or those patients received minimal bortezomib with less than 8 doses. So the data cutoff for today's presentation was October 25, 2011. At that time, 68 patients were enrolled, and the safety data was available for 61 patients. Because the patient has to be treated after 2 cycles to get a first restaging study. So only 51 patients at that time had finished more than 2 cycles. Therefore, they have this imaging study to assess the stage. Therefore, only 51 patients at that time was accessible for response. Among those 51 patients, 31 patients was bortezomib naive, and 20 patients received prior bortezomib. In order to be eligible for the study, the patient must have tissue diagnosis of mantle cell lymphoma. It have to have relapsed setting, received at least 1 prior line of therapy. The patient should have adequate bone marrow function, adequate performance status with no significant other clinical comorbidities. There's a 68 patient enrolled, and the features of the patients was in terms of age, gender, time from initial diagnosis, ECOG performance status, prior therapies was quite similar, almost identical in the 3 groups in terms of total group, and the bortezomib exposed group, and the bortezomib naive group. The features of the prior high-dose intense therapy, mantle cell lymphoma IPI score, what is called the MABI score, and the bulky disease. Bulky disease is defined that the patient have a tumor, with at least 1 tumor with more than 10 centimeters in the longest diameter, and the stage 4 disease, refractory disease to the last therapy prior to starting entry. Those features were quite similar, with no statistical difference among the 3 groups in terms of the total and the prior bortezomib naive or bortezomib exposed. Please pay attention that the 12 to 15% of the patient had a bulky disease. The 3 groups was also quite similar in terms of time on study, patient still on study at that time, and a patient with a discontinuation and a death. I will explain this 1 death. And that study was at that time of the presentation was really early. About 3 points, the median time duration on study was only 3.7 months. Of course, the range was much longer, but the median was 3.7. 1 patient died from pneumonia while he was after 2 cycles therapy. This patient was the potential relationship to the study cost could not be ruled out, and this was therefore included in the data support report. This, I believe, is in the Ohio site. After more than 200 cycles of PCI delivered to those patients orally, these are the toxicities regardless of their relationship to the study drug. That means even if the toxicities are not related to the study drug, they are still listed here. And of course, they include the potential toxicity that's related to the study drug. As we can see, the majority of the side effects are grade 1. That included fatigue, diarrhea, dizziness, nausea, dyspnea, peripheral edema, and rash and abdominal pain. So grade 2 toxicity was less, was also among the similar pattern of the grade 1 toxicity. Scarcely any, very few grade 3 toxicities. There's one grade 4 toxicity that's non-hematologic. That was actually a grade 4 toxicity due to abdominal pain. The patient had abdominal pain due to the mantle cell lymphoma actually progressed during the therapy. And therefore, the pain was due to the progression of mantle cell lymphoma in the abdomen, and so to the best of our knowledge, this toxicity was not related to the study drug. So that slide was the non-hematologic toxicity. This slide is on the hematologic toxicity, grade 3 or 4, irregardless of their relationship to the study drug. As we can see, we observed 3% grade 4 neutropenia that did not translate into any grade 4 febrile neutropenia, and we had 2% pancytopenia, and grade 3 about 2 to 3% of grade 3 myelosuppression. And so to the best of our knowledge, with a very early on study, so far, no significant or very mild bone marrow suppression has been observed on the study. Among the 51 patients with a single agent PCI, the total response rate was 69% for the whole group. And this included partial responses and also 18% complete remissions. 18% complete remissions, the criteria is defined by CT scan, confirmed the PET-CT scan. The bone marrow has to be negative, flow cytometry has to be negative. If the patient has prior GI disease, that has to be negative by upper and lower endoscopies with random biopsies. And so that's the response rate was 69%, 18% CR rate. And this response rate was not statistically different among the patient that was bortezomib naive or bortezomib exposed. As you can see in the exposed group, 65% response rate and 71% in the bortezomib naive. This is one of my patients who were treated with a study drug. He has a neck mass on the right side, as you can see in the picture. This is the picture was taken on day 2 of the study. And his peripheral lymphocyte was at the baseline. 8 days into the study, by my physical examination, the tumor has shrunk more than 50% of its original size. The lymphocyte peripherally was observed to be increased in the peripheral blood. 15 days into the study, the tumor was no longer palpable on the physical examination, and the lymphocyte went further into, increased a little further in the peripheral blood. Day 22, the tumor stayed not palpable by clinical examination, and the lymphocyte has plateaued. If we did flow cytometry for the increased lymphocytosis, we found the co-expression of CD5 and the CD19 cells that is very indicative of with a sensitivity over 90% of mantle cell lymphoma cells. That's how we actually diagnose with mantle cell lymphoma, co-expression of CD5 and CD19 on the same cell. So could it be that the tumor cells has shifted their compartments from where they originally stays? The original size of the mantle cell lymphoma cells, as we know, is in the lymph nodes, in the lymph node mass, or in the bone marrow exam. if it's positive. So could it be that this medicine, this BTK inhibitor, has triggered the migration of the cells from the tumor compartment into the peripheral blood? We have observed, we have data from our side among 30 patients, with the majority of the patients has undergone this lymphocytosis that was transient. And we so far think there's a compartmental shift phenomena. The tumor cells might have shifted from their original compartment into the peripheral blood. We are very intrigued by this phenomena. There's other sites, investigators, that's confirmed so far, and is actually a very hot area for study. The best responses among all the patients, and as we can see on this column on the right, and 57% of the patient achieved response, even they had a bulky disease. This is 4 out of 7 patients. And most importantly, look at the prognostic factor. The MWang score is widely used for mantle cell lymphoma prognosis, and you can tell the difference between different chemotherapies, and you can tell the difference between prior transplant or not. But among those 3 prognostic groups by MWang score, low risk, high intermediate risk, and high risk, and the response rate so far is there's no difference, which indicate that the traditional prognostic value makes no difference when you use the new agents. We have observed this in multiple myeloma, where keyed bortezomib actually can overcome the deletion 13. We also have data the carfilzomib could also do the same. So the novel agents are challenging the traditional prognostic system that we have been using. Time on study to the best response. Some patients started with a very small response, and with a progressive time, some of the patients with a minimal response changed in the PR, some of the PR patients changed into the CR. And actually, our site has 6 months after the 3-point met. We have 6 months more data duration, and we are seeing much more CRs. And I would like to update this in the next major conference, me and my colleagues. The duration of the response with a short interval so far was quite very indicative of a durable response, and so far it's as you can see that the duration could be long, and it depends. Sometimes the patient did not have a longer follow-up, so this curve actually grows with time. So in conclusion, PCI is a selective, irreversible inhibitor of the beta-Bruton's tyrosine kinase. PCI induced a quite high response rate as a single oral therapy in mantle cell lymphoma in the relapse setting. PCI is associated with quite a favorable safety profile. There's no significant myelosuppression so far observed. It's very important to realize this is only preliminary data. We need more data with more time on the study. There's an ongoing this is an ongoing study, and accurate determination of the duration of response and failure-free survival, and need a longer follow-up. And more clinical trials are being designed for registration in mantle cell lymphoma. We thank all the patients who participated in the study, the families who supported them. We thanked all the 8 international centers who enrolled on this study, and we also thank the pharmaceutics to support this study. Thank you.
So I think just because there is a slight difference in the topics that we're thinking about during this session, I think we'll take questions on this presentation from Michael now. Has anybody got any questions? I might start off with a few. I've written a few down here. So the compartment
you don't
phenomenon.
have to talk to me in Chinese.
No.
Speaking
I'll try English. The compartment observations are very interesting. Mm-hmm. Do you have any particular ideas about why that occurs? And possibly more importantly, are there certain compartments that appear to be resistant to the effects of BTK inhibition?
David, or I'm sorry, Dr. Ritchie, this is this great question. I mean, asked many times. So far, we observed this compartmental shift syndrome with two medicines. That's tyrosine kinase inhibitors. One is Cal-101, another is this kinase inhibitor. And so far, this is the two most prominent. And then occasionally, when I use the lenalidomide to study the mantle cell lymphoma, I occasionally see this shift. And in very rare cases, I saw some compartmental shift with the novel agents in multiple myeloma. So this mechanism is quite more pronounced with mantle cell lymphoma with the BTK. That's the first part of your question. The second part, could this be part of the mechanism in the resistance or sensitivity? If the agents are not able to dislodge the tumor cells from the original compartment into the blood, so could that cells stay in their microenvironment, could not be shifted? Could those cells be responsible for the later resistance? There's lots of robust activities on the preclinical testing at this time. There's so far no data to see that.
Thank you. A question.
Yeah, hi, Satya Yadav from India. Just regarding side effects of this new agent, would it lead to A-gamma globulinemia if you're trying to block BTK, which is what we see in children? It's a known immunodeficiency. So did you check the immunoglobulin levels, and was it a problem, or did you anticipate in pre-clinical trials?
Thank you for the question. That is a very insightful question, because if you knock off the BTK by the gene mutation, you knock this off, and the animals would develop A-gamma globulinemia. They have zero IgG, IgM, IgA. So therefore, that's why this question is so insightful. But with that in mind, we actually have checked the immunoglobulins on each and every patient, which is a part of the protocol. We did not detect any significant differences. So we oftentimes have low immunoglobulins because of prior rituximab usage. But during the study, we did not see any change.
Any other questions? Perhaps I can have one more. So it's very interesting how you saw equal responses in patients who'd been exposed to Velcade previously or not. Were any of the patients who had been previously exposed to Velcade resistant to that? And if they were, if they had resistance from it, not relapse from it, but primary resistance from Velcade, did they still show sensitivity to BTK inhibition?
Yes, there's less than half of the patients had in the bortezomib exposed group. Among the bortezomib exposed, there are two scenarios that is sensitive or refractory. Our sample size so far are too small to make a conclusion remark, but so far the refractory cases responded to this drug as well, but with the few patients we had, about 10 patients.
Okay, well, thanks very much, Michael, for a very interesting talk on a very interesting drug.